We'll start the last session for this day, nice day. The last session include many subjects. The first subject in this session will be by Dr. Vinay Dhir. He is Director, Balodet Institute of Digestive Science, Bombay, India. Her subject will be intervention access to biliary system, percutaneous versus ERCP versus EOS current trend. Welcome, Professor Vinay. $20 minutes, inshallah.
Thank you very much, respected chairpersons. At the outset, I would like to thank the SGA.
Voice, Doctor.
Voice is not coming? Now is it okay? I would like to thank the SGA for giving me this opportunity to be with all of you. My topic today is interventional access to biliary system. Which route to use, percutaneous, ERCP or EUS? So as you all know, biliary access is required before we plan any therapy, be it a removal of stones or stent placement, management of strictures. You need first to enter the biliary tree. You can enter the biliary tree from multiple sides, transpapillary, you can go via the papilla. You can go it from the left or right intrahepatic biliary radicals, or you can enter transduodenal. And the available techniques to enter the bile duct or the biliary system are surgery, the percutaneous method, and endoscopy, which involves ERCP or EUS. We are not going to discuss surgery today because that is not part of the topic. When we are comparing different techniques, we should compare the safety of the various techniques, their efficacy, how efficacious they are in the short term or on the long term. What about their cost, relative costs? And I think the most important point is availability. Is the particular technique available where you are practicing? And I think that becomes an important factor in real clinical practice. So if you have percutaneous method available and you do not have EUS, you will obviously go for percutaneous method. Briefly about ERCP access, it's almost 4 decades that we are practicing ERCP now. We access the bile duct through the natural route, that is, we go through the papilla. So it needs an approachable papilla to be able to do an ERCP. Hence, we will have problems doing ERCP if there is a duodenal stenosis, if there is a post-surgical anatomy, a post-Whipple's patient or a Bildor 2 patient, or you have an approachable papilla but you are not able to selectively cannulate the bile duct. And what is the worrisome problem with ERCP? Pancreatitis is the most worrisome problem of transpapillary access. I'll show you briefly how the standard wire-guided technique is done for ERCP, a very brief video. You'll have to excuse me because of computer glitches. We will have to do like this. So here is your papilla, oriented nicely at 11 o'clock position. You see the wire there. The wire is oriented in the bile duct direction, 11 to 1 o'clock. Shall I make it big?
Yes.
Okay. Maximize it. So here, once you are in the proper axis, you are into the bile duct. So fairly straightforward technique. It is highly successful in majority of cases, and hence it remains the procedure of choice for us. How do I go back now?
done with this video?
Yeah. Okay, thank you. Percutaneous access, we go via the liver, so go via the skin and then go into the right or the left biliary system. The advantage is that prior surgery or duodenal stenosis is not an issue. However, most of the places a two-step procedure is done where first an external catheter is placed and then the stent may be internalized. Problem here is a high rate of reintervention. Very often the catheter can dislodge, there can be infections, functions start to deteriorate rather rapidly, so reinterventions are required. The new kid on the block is the EUS guided access. The advantages of EUS guided access is you can access the bile duct from the transgastric route, that is approaching via the left intrahepatic radical, or the transduodenal route. So hence duodenal stenosis or post-surgical anatomy is not an issue, just like percutaneous route. However, currently it is limited to very few specialist centers, and the problem with this procedure is bile leak. I'll show you few videos of EUS access. There are multiple procedures depending on what is the site of access and where is the stent exiting. So, for example, if you do a rendezvous procedure, okay, here I'll maximize it. Here is a 19 gauge needle. My scope is here. You can see here I am in the bile duct. Once you aspirate the bile, inject contrast, you can see my needle is looking towards the hilum. Highly wrong position for a rendezvous, but this is our learning phase video and I wanted to show this to you that initially it happens and then you need an expert handler of the video guide wire. So your assistant should be good, who can manipulate the wire down across the papilla into the duodenum. Once the wire is into the duodenum, you remove the echoendoscope, place the duodenoscope, the ERCP scope by the side and complete the ERCP. So this is the rendezvous procedure. If you want to place a stent directly, you can use, okay, this is another rendezvous video. I think I should stop this. Here is the Colidoco duodenostomy video. Again, 19 gauge needle. This is the bile duct. This is not playing. Okay, it's playing. So you enter the bile duct, inject contrast, you see the biliary system, pass your wire up into the hilum, pass a catheter to dilate the tract, and then place a stent. Fairly straightforward procedure, should finish in about 10 minutes time in experienced hands, and decent rate of complications, not very high. See, you see here the wire is the catheter is passed now, and now a stent is being passed. So this is EUS guided Colidoco duodenostomy. You need a covered stent here so that to prevent bile leak. See here we are deploying the stent now. This is a EUS CDS. If you want to approach the hilum, then what you can do is hepatogastrostomy, where you approach from the proximal stomach and puncture the dilated left intrahepatic biliary radicals. See here, you are into the left radical, aspirate bile, confirm that you are in the biliary system, inject contrast, then dilate the tract, and once you have dilated the tract, you can place a stent. You have to place a stent in such a way that it is about 3 to 4 centimeters projecting into the stomach, otherwise there will be migration. So this is how a hepatogastrostomy is done. See here, a stent is being deployed now. So just like ERCP, the stent deployment, but here you have to be careful in the stomach. Leave a longer length of stent in the stomach, otherwise there are chances of migration. So this is a hepatogastrostomy. And finally, there is a procedure called as antegrade procedure, which is just like PTBD. So again, we attack from the left side of the liver, proximal stomach, 19 gauge needle, pass the wire. But unlike the hepatogastrostomy which I showed you just now, here you have to pass the wire across the hilum and the stricture. So here there is a post-Whipple's recurrence. You can see the clips here. So you have to pass the wire across. So this is antegrade procedure, and the stent will be deployed between the jejunum in this case and the bile duct. It will not be deployed here between the stomach and the biliary system. So this is a cystotome. We use it for tract dilation. Once you confirm that you are in the jejunum, withdraw the cystotome and place expandable stent over the wire. It's a fairly straightforward procedure, provided you have an expert assistant to pass the wire across the papilla or across the surgical anastomosis. This is known as antegrade procedure. So these are the variations of EUS guided biliary drainage that are being practiced all over the world now. And let us now critically evaluate each of these procedures one by one. So see here, the stent is deployed nicely. Confirm that you are nicely in place here. So this is the antegrade procedure. Now how do I go back to the presentation here? Let's look at the evidence now. For the evidence, I'll go to this recently concluded Asia Pacific Consensus Recommendations for Difficult Biliary Access. This was a collaborative effort between Digestive Endoscopy Society of Taiwan, together with TCAP, Professor Isayama is sitting here, and Thai Association of Gastrointestinal Endoscopy. About 20 experts on surgery, interventional radiology, and endoscopy, EUS, ERCP, sat together and developed a consensus statement on difficult biliary cannulation, and this is going to be published very soon. So most of the data that I'm going to show you is from there. So ERCP remains the standard procedure for biliary access and therapy as of today. And why is it so? Because it has a high success rate, modest complications, it is widely available all over the world, and we have a level 1 evidence to show that it is safe and effective. When I am talking of ERCP, I am talking of standard cannulation, wire-guided cannulation, or with a standard catheter or sphincterotome-guided cannulation. That is the safest and the best procedure as of today. In normal anatomy, the success rate is pretty high, with a pooled success rate of 89% in one recent meta-analysis. However, in surgically altered anatomy like Bill.2 or Roux-en-Y, the success rate is much, much lower. This is a prospective data of ERCP. This gives a real picture because this is community data. This data is not coming from highly specialized center. So this is a multi-center Norwegian data published 2 years back. So you see here good success rate of ERCP, 91%, 11% complication rates, 3.1% pancreatitis, and 2.2% mortality. So ERCP remains the procedure of choice. In about 15% of patients, there are problems. You cannot access with the wire or with the sphincterotome, and that is where the complications increase. So this subset of patients, you need specialized techniques. So the prevalence of difficult cannulation varies, as you can see from these studies, from 5% to almost 49%. Different centers have different difficult cannulation rates, and if you have higher rates of difficult biliary cannulation, I think the complication rates at your center are likely to be higher, because you are then going to use more advanced techniques to access the biliary system. So we have advanced ERCP access options in difficult biliary cannulation once your normal cannulation is not possible. In patients with normal anatomy, you do pre-cut papillotomy, transpancreatic pre-cut, fistulotomy, or double guide wire cannulation. Patients with post-surgical anatomy, you do enteroscopy assisted ERCP. So these are the various options which are being evaluated. Pre-cut remains the oldest of them. I'll just show you a brief video of pre-cut. Fairly standardized procedure now. See here, cut it in the direction of the bile duct, basically de-roof the papilla layer by layer in the direction of the bile duct. And once you have identified the bile duct, you cannulate, and it should not be difficult to cannulate and then see a cholangiogram. So this is the pre-cut, and pre-cut has been identified as okay, where is that? Where is my presentation now? I'm sorry about this because oops, yeah, everything went.
You want your presentation?
Yeah. Okay, thank you. Yeah. So these are the results with pre-cut and needle knife fistulotomy, and although those who do a lot of pre-cuts, they will say it's a very, very safe procedure, but if you look at the literature, the prevalence of pancreatitis and bleeding is higher in patients who undergo pre-cut. It could just be that higher pancreatitis indicates a difficult cannulation, and the higher pancreatitis may not be because of pre-cut per se, but there is a higher rate of complications with pre-cut. Another technique which is being popularized is double guide wire cannulation. Oh, you'll have to help me again. I'm sorry, I'm very sorry. Where are the videos? Okay. So this is really becoming a... Okay. You know, I shouldn't have brought so many videos. So if you are going into the pancreatic duct repeatedly, see here, keep a wire in the pancreatic duct, and then by the side of it, try to cannulate into the bile duct. So you bring out your sphincterotome, align it above and to the left of the pancreatic duct wire. You can also pull the pancreatic duct wire in different positions to help your alignment. So see here, we are doing all this, changing the position of the pancreatic duct wire to get a better alignment with the bile duct. Once you get a good position, you go in to the bile duct above and to the left of the pancreatic duct orifice. So you already know that the pancreatic duct orifice is here. You go above and to the left of it, try to cannulate, and you will succeed. But also here what you are noticing is there is a lot of papillary manipulation. And so it is not surprising that pancreatitis rates are pretty high, actually higher than pre-cut with double guide wire cannulation techniques. However, there are some who swear by this technique and say that if you are having repeated pancreatic duct cannulations, better to leave a wire there and do a double guide wire technique. So here you can see now we are in the bile duct. Still trying, not in the bile duct still. Here, okay, you got the right angle and got the pancreatic duct cannulation. So you can see here, this is a wire in the bile duct. So this is the double guide wire technique. And then coming back to my presentation, there are reports of enteroscope assisted ERCP. Professor Isayama is sitting here, a big expert in enteroscope assisted ERCP. Just briefly, it succeeds in about 80% of cases as far as reaching the papilla is concerned, but ERCP per se succeeds in about 65% of cases, and this rate is improving steadily with better enteroscopes being available now. So enteroscope assisted ERCP is useful in patients with post-surgical anatomy to access the bile duct. EUS guided access, what are the results? Let us quickly see. So I already showed you the access routes. You have transhepatic route, transgastric route, and transduodenal route. In the transhepatic, you have a B2 route and a B3 route, depending on which radical you are trying to access. So these are the various pictures. How do you manipulate your scope to gain access in different directions? See here, scope looking down, scope looking up, scope horizontal. These should be tried and attempted to get the desired position. The advantage is there are multiple routes available with EUS, but which route should you choose if you have both the routes? Conflicting data, this is our own study of Rendezvous, where we showed that transjordanal route is better. This is another study, multivariate analysis we did, published in DEN 2014, which shows that transjordanal route is safer compared to transhepatic route. Now this is a problem. Okay. This I'll have to show in the big one, otherwise it won't play. See, I had created some effects.
So Dhir, another 2 minutes, please.
This will not come. There is no way this will come. So basically, I'll just summarize that this is a compilation of large 6 studies, 500 EUSBD patients, and the success rate of EUSBD in these large studies is 90%, and complication rate in these 500 patients is about 13%. So, in expert hands, today EUSBD is safe and effective. However, there are very few centers doing this as of now. What about comparing these access routes, EUS with ERCP? We have published 2 studies, one in 2012 comparing Rendezvous with pre-cut papillotomy, and there is absolutely no difference in the results of the 2 techniques. And recently we have published this study comparing ERCP with EUS. Again, exactly similar results, 7 centers all over the world, 208 patients, no difference in success and complication rates of ERCP and EUSBD. However, if we separate the difficult cannulation patients, EUSBD seems to do better. There are hardly any pancreatitis except in those who underwent antegrade procedure. What about comparing with PTBD? This is another of our study. Abstract was there in DDW last year, 128 patients, 64 underwent PTBD, 64 EUS-RV. No difference in success rate and complications. However, with PTBD, there are higher number of re-interventions are there. So, comparable to ERCP and PTBD in expert hands. That is the consensus so far. So, the summary of all this evidence that we have is that if you have a difficult cannulation in normal anatomy, you can use EUS, percutaneous or ERCP depending on the expertise available at your center. In BILDA2 anatomy, you can use a device-assisted enteroscope, EUS guided drainage or a percutaneous drainage. If you have a roux en Y anastomosis, the options are more limited. You cannot obviously do ERCP, so you are limited to device-assisted enteroscope, EUS guided drainage or percutaneous drainage. So my conclusions are that transpapillary access via ERCP is the procedure of choice today for biliary access. Complications are higher if biliary cannulation is not achieved via the standard method. And then we have a number of procedures which I showed you, which are still under evaluation for patients with difficult cannulation, and we will need further studies to assess their relative value. I invite you all to Mumbai in March 24th to 26th if you want to see a lot of interventional EUS cases. One of the photos is missing here, and that is of Professor Majid Al-Mahdi. This was made last year. So Professor Majid will be an esteemed faculty with us in Mumbai in March. Thank you very much.
Thank you, Dr. Dhir. Will be the question in the last session, inshallah.
Thank you.